My topic is a surgical approach to the common femoral, superficial, and popliteal artery. In 8 minutes, I do have some disclosures. I am an 18-year-old practicing surgeon that performs also endovascular procedures. Allows me to have a very good training in open as well as endo. I think the newer generation of our fellows that were trained in institutions right now are going to receive less and less open exposure and experience, which is going to eventually condition the future as well as a working force. The second one is surgery punched first. And when you punch first, you punch twice. So we established ourselves as kind of the leading alpha role in occlusive disease because we were there first. But endovascular therapy has rightfully challenged every segment of the femoral popliteal territory because of relentless technical and technological evolutions and the inherent surgical shortcomings. Every time we expose an artery through a surgical wound, we increase the systemic complications rates. We also increase the local non-vascular complication rates, which most of the studies that you've seen today seem to be driving surgical safety, favoring endovascular approach. Also, we have failed over 50 years of producing off-the-shelf technology that is easier than harvesting autologous venous conduits to replace or bypass obstructive disease. So you can clearly acknowledge today that every patient in the femoral popliteal segment is an endovascular candidate. Just some are better than others. In essence, the benefits of endovascular safety must be weighted against the superior surgical durability. And I say durability for the time being. But the randomized control data still suggest that in fit patients who will live more than 2 years, the improved durability of this procedure should be outweighed when you have suitable single-segment greater saphenous vein. Despite that, endovascular approach, as we all know, has increased, bypass has decreased, training paradigms are changing, and the amputation rate has been pretty stable for the last couple of years. Now, this reflects our own practice paradigm as well. 30% of what we do is open peripheral interventions, and 60–70% essentially is endoluminal. We do have very good guidelines in the surgical literature about how to avoid infections when we do bypasses, not doing bypasses for claudication, not using prosthetic material below the knee, and utilization of a single greater saphenous vein. And don't take too much time because too much time doing bypasses is negative for the patients. The indications have not changed from us to you, from you to us, should continue to be respected. The segments are the same, the anatomy is the same, and the surgical techniques that we utilize are bypass, remote femoral endarterectomy, and common femoral endarterectomy with patch angioplasty. Autologous and non-autologous conduits are used, although single-segment greater saphenous vein is by far the important one. There's a lot of things that happen when you perform these bypasses, difficult to learn, long learning curve. Again, you need volume, you need time to develop this type of procedures. But nevertheless, above and below the knee consistently, greater saphenous vein is superior to any other form of conduits. When we don't have that, we have explored alternative conduits, and the arm veins seems to be better than the prosthetic graft above as well as below the knee. In terms of alternative conduits, in terms of comparison, there is an increased risk when you use alternative conduits for transfusions and systemic complications as well. Now, our important point is what is the outcome of a bypass that is being offered to a patient after a failed endovascular procedure. And there's a good paper for the Mayo Clinic, 566 patients. And you can see that the overall number that needed to be, that required open bypass surgery was 30. So only 5%. So this is a low chance event. Nevertheless, there is some changes in terms of the pre-intervention target to the post-intervention target. And if we talk about overall durability of the patients that receive above knee versus below knee bypasses, the durability of that procedure and the outcome of that procedure clinically is actually inferior. So although I heard through the meeting that sometimes you wouldn't bypass to a diseased vessel, and I agree wholeheartedly with that, when endovascular procedures go wrong or the thrombosis after a failed endovascular procedure it's there, that may change the target vessel for if you were to be done de novo open bypass. But it's not justified because only 5% of the patients will receive that. Remote endarterectomy is another option that we offer, and again, it's just a combination of hybrid common femoral intervention plus SFA intervention as well. It's been compared to venous bypass, which is less, and it's been compared to prosthetic, which is better, remote endarterectomy, as well as it's been compared to endo. And in TAS D lesions, at least in Italian trial, randomized trial, the endo approach was inferior to remote endarterectomy in this single group. Common femoral has been addressed at the beginning of this lecture, so I won't talk too much about that, except that it is kind of the last frontier, and there's been some randomized control trial that supports probably the increased utilization of endovascular approach to it. So, what is your place in the world if you are a vascular surgeon in order to offer bypass surgery? I think we have largely replaced open femoral popliteal open interventions, and I think we all embrace endoluminal approach. Nevertheless, the current primary role continues to be common femoral occlusions, complex common femoral with profunda disease, as well as a secondary role after failed endovascular approach. Thank you very much for your attention.